came to the casualty, the chief complaints of involuntary movements of the lips, which is associated with frothing from the mouth and tongue bite, which is present for 4 minutes. There were 2 episodes, and with post-ictal confusion 5 minutes, and then patient was immediately turned to the left lateral position, and then injection lorazepam 2 cc was given, after which she regained the consciousness, and there were no further episodes of seizures. No history of fever or headache, no history of trauma or any fall. Past history, not a known case of hypertension, diabetes, epilepsy, no history of similar complaints in the past. General examination, patient was in the post-ictal confusion state. No pallor, cyanosis, clubbing, lymphadenopathy. Her BP was 110/70, pulse rate was 118. On that day, we diagnosed her as new onset seizures under evaluation, and we treated her with Livable 1 gram in 100 ml NS IV stat, and we gave her injection lorazepam 2 cc stat. After that, we sent her to MRI. Contrast MRI, in which
any focal neurological deficits or any positive CNS findings, like we have to see for meningeal signs such as Kermit's before we further evaluate the case. First we have to general examine the patient. All the patient general CNS examination works, and we have to say this CNS examination.
In CNS examination, there are no neurological focal deficits, and then we sent her to MRI contrast.
Meningeal signs?
No, sir. And then, well, normal.
How about the plantar response? Okay. Right is withdrawal. Is of normal, and right is of withdrawal response.
MRI contrast report showed well-defined cortical based enhancing lesions. GTCS type of seizures.
So, how will you approach a case with the seizures? Like, what are the causes you will be ruling out, and what could be the possibility of seizures? So, first we have to evaluate the cause. How will you approach the case of a seizures?
Seizure patient, whenever in a serious case, you have to think in 2 main differences. One is structural defect or a metabolic defect. Okay, that is the basic classification. Again, going to the structural cause, you have to see the type of seizure. Is it a generalized seizure or it is a focal seizure? Generalized seizures usually have a metabolic cause, and structural causes usually present as a focal seizure. And what was the type of seizure in your patient? GDCS. So first, before sending the patient to MRI, as you have said, there are no focal deficits. You have to rule out the metabolic causes. Any other history other than a seizure episode?
No. She was her periods were not regular, so we sent her for thyroid.
So she was absolutely normal before this seizure?
Yes.
No other health issues or no toxin
This
exposure?
is her first admission in the hospital.
No previous comorbidities or drug history?
No.
Nothing is this.
No, she used tricoton tablet. She said that.
Do you think it is related or relevant?
No.
Okay, so the patient is not having any focal deficits. So in that case, we go for a metabolic cause initially. Rather than shifting the patient to MRI, we think of any metabolic cause. First, when the patient came with seizure, as you said, we will put her in left-lateral position. We initiate the treatment with benzodiazepines for acute seizure. Okay, and then you shifted the patient to MRI. And what were the investigation findings? Like, tell the metabolic and MRI both.
Serum phosphorus was 3.91, calcium was 9.8, magnesium was 1.9. And then on LFT, total bilirubin was 0.74. It was all was normal.
LFT is normal.
LFT is normal.
What are the metabolic causes of seizures? You told most of them. Okay, hypoglycemia. You read out those reports, no? Hypoglycemia, hypomagnesemia, any electrolyte disturbances can cause. And apart from electrolyte disturbances, what can cause seizures? Uremic encephalopathy, hepatic encephalopathy, and any focus of sepsis is there. Sometimes septic encephalopathy or hypoxia, all these can cause seizures. So there is nothing in your patient fitting into a metabolic cause. So you have done an MRI. Tell the MRI findings.
MRI findings were there was a well-defined cortical-based ring-enhancing lesion which is seen in the right frontal lobe, which is measuring 13 into 13 mm with surrounding perilesional edema and mild surrounding leptomeningeal enhancement.
What is the differentials that they are given?
They have given neurocysticercosis stage 3 and tuberculosis.
Is there any way that you differentiate NCC from tuberculoma in neuroimaging?
In imaging, location mainly, if it is neurocysticercosis, it will be in the gray matter. If it is tuberculoma, it will be in the posterior fossa. So here it is in the gray matter, at the junction of the gray matter. So that one, and she don't have any meningeal signs. It depends from tuberculoma.
Tuberculoma is different, tubercular meningitis is different. Now you don't need to, there is no need to have meningeal symptoms. In MR, I'm asking you, imaging, is there any way to differentiate? Specifically MR spectroscopy.
Multiple weeks.
Can you please tell about MR spectroscopy, Vinay?
It is a specialized non-invasive technique where it studies the metabolism of these cells, where we study about the diseases such as how to metabolism of neurons, where we see the Alzheimer's disease, seizures, and also multiple diseases.
Corticosteroids reduce the rate of seizure recurrence in 6 to 12 months. 1373 participants were included. The quality of the evidence was deemed to be very low. So the corticosteroids alone versus placebo reduced the rate of reoccurrence of seizures in 6 to 12 months. It is the meta-analysis of RCTs. So the conclusion says that although the evidence suggested corticosteroids can reduce the rate of seizures reoccurrence and speed up resolution of lesions at 6 to 12 months of follow-up, there remains uncertainty on the effect estimate due to high risk of methodological and publication bias.
NCC, the inflammatory response in the humans are not well studied but probably reflect the stages of degeneration. The response usually consists of varying degrees of mononuclear infiltrates, mostly made up of lymphocytes, macrophages, and plasma cells. Eosinophils, depending on the stages, the present to varying degrees and may make up a significant part of the inflammation. Giant cells are occasionally present in the granulomatous inflammations. In infected pigs, which are only available animal models, there vary degree of granulomatous infiltration surrounding the parasite, with more development granulomas showing increase in cellularity and the presence of epithelial cells adjacent to the parasites. So, these studies, NCC have generally been limited to description of the profiles of inflammatory mediators or phenotypes of T cells in subsets of patients manifesting various degrees of inflammatory pathology. So most of the studies have reported pro-inflammatory states during the symptomatic periods and asymptomatic chronic diseases states associated with the regularity. These observations, investigators have suggested that acute symptomatic individuals with NCC have the Th1 type profile in the peripheral blood. Effects of corticosteroids and immune response. Glucocorticoids as a class of steroids hormone exhibits potent immunomodulator activities, almost all of which occurs following the bindings of glucocorticoid receptors in the cytoplasm of immune cells. So, GR, that is glucocorticoids, like the cytoplasmic receptors for GC, and there is normal bound and to get inactive by chaperone protein such as eat shock protein. Corticoids are employed to suppress ongoing inflammations in the chronic suborchidine and ventricular NCC, either associated with the treatment and consequences of the natural course of the disease. The author is to be commonly uses 10 to 16 mg dexamethasone in critical and severe NCC associated with the inflammation. Subsequently, dosing depends upon the effectiveness of the treatment and the degree of the clinical improvement, loss of edema, and enhance as assessed by MRA. Information favoring one of the type of corticosteroids over any other, because dexamethasone has a little mineral corticoid activity. We favor